Thank you, ma'am. Uh, Today, I'll be presenting a patient by the name Mr. Ramu, 28 years old, male, who was previously a tractor driver by occupation and now works at a departmental store, hailing from Shira, who the informant is himself and his mother and is reliable, who's a right-handed individual. He presented with chief complaints of headache, vomiting, and fever for 15 days 1 year back, followed by altered sensorium for 1 day 11 and a half months back, and bilateral lower limb weakness since 11 months, associated with difficulty in passing urine since 11 months. History of presenting complaints. Patient was in his usual state of health till 1 year back when he had history of headache, which was holocranial, severe in intensity, associated with photophobia, with no blurring of vision, no aggravating or relieving factors, with no diurnal variation lasting for 15 days. This was accompanied by history of vomiting, projectile vomitus containing food particles, non-blood tinged, non-bilious, multiple episodes per day, not related to consumption of food or pain abdomen for 15 days. This was also associated with history of fever, which was low grade, not associated with chills, associated with night sweats and evening rise of temperature, relieved with medication for 15 days. Following this, the patient then had progressed with the patient having altered sensorium. That is, the patient's mother gives history of the patient being drowsy and had decreased responsiveness, for which he was brought to the hospital. Patient's mother gives history of the patient being admitted for above complaints, and in view of altered sensorium, a brain scan was done and fluid from the back was removed, following which he was started on treatment for the same, and during the course of hospitalization, patient's sensorium improved. However, for the next 15 days post admission to the hospital, patient noticed weakness of both the lower limbs, such that he noticed weakness in both the lower limbs. There was heaviness and had difficulty in moving both the limbs on waking up, which then progressed to the patient not being able to move both the lower limbs at all over the next 2 to 3 days. This was associated with the patient having difficulty in turning in the bed from side to side and from getting up from sleeping position, such that he required the support of both the upper limbs to do so. However, there was no difficulty in combing his hair, buttoning or unbuttoning of his shirt, and this was also associated with difficulty in passing urine, such that the patient was unable to void urine and was catheterized in view of the same. No history of fever during this episode, no history of weight loss or cough, no history of tremulousness of hands or clumsiness while raising his hands, and no history suggestive of cranial nerve involvement, no history of difficulty in perceiving hot and cold water while having a bath, no history of backache or neck pain or history of girdle-like sensation, no history of difficulty in perceiving hot or cold sensation while having a bath, no history of loose stools, high-risk behavior, no history of involuntary movements of limbs, no history of recent vaccination. During this episode, the mother gives history of a spine scan being done for which which was reported to be normal. Patient was continued on treatment, showed minimal improvement in weakness such that the patient had slight movements of both the lower limbs. A repeat test of the fluid from the back was done, told to have improvement, and was discharged with medication and was wheelchair bound and was catheterized at discharge. During the next 2 months, the patient noticed no improvement in weakness, however, developed headache similar to the first episode, not associated with diplopia vomiting, had associated neck pain, which was severe in nature, not radiating to the upper limbs, for which he was admitted. A repeat scan of the brain and spine was done and was advised surgery in view of the same, following which his headache reduced. The patient continued to have bilateral lower limb weakness during this episode and had difficulty in passing urine with urgency and increased frequency, for which the patient continues to use a U-dream, that's a condom catheter. Patient was continued on his previous medications and a course of antibiotics were given and the patient was discharged. Patient presented to the hospital 5 months back in view of no significant clinical improvement of both the lower limb weakness, in view of which fluid was again removed from the back and the patient's treatment was altered such that the patient was started on a daily injection which he took for 2 months. Patient has taken treatment for the above complaint since over a year and has now returned to the hospital in view of no significant improvement of clinical condition. That is, the patient currently has weakness of bilateral lower limbs with difficulty in turning in the bed or getting up from sleeping position and is mobilizing with the help of a walker minimally. No history of loss of smell, vision, or taste, no history of difficulty in speaking or hoarseness of voice, no history of thinning of limbs, no history of tingling or numbness of all four limbs, no history of altered behavior, no history of fall, trauma, or ENT bleed, no history of band-like sensation, no history of altered behavior, and no history of tingling sensation of the back on bending his neck. Past history. Patient is a known case of seizure disorder, had involvement of all 4 limbs, that is since the age of 18 years, had 2 episodes and was started on treatment for the same. However, patient discontinued the medication after 3 months by himself. He had childhood history of dog bite at the age of 8 years and has completed vaccination for the same. No history of similar episodes in the past. No history of diabetes, hypertension, thyroid disorder, tuberculosis, or cardiac disorder in the past. Family history, he's born out of a third-degree consanguineous marriage, and his paternal uncle died due to pulmonary tuberculosis. Personal history, he consumes a mixed diet. The appetite is normal. No sleep is adequate. Bowel movements are regular. Bladder, he has a uterine in situ. And no deleterious habits or high-risk behavior. No history of exposure to toxins.
Okay. Finish up drug history also.
Drug history
Now, drug history, you keep it off. We will discuss the case first. So, first, how do you, first symptom is headache, no?
Yes, ma'am.
So, what is striking about that headache?
It was holocranial, ma'am. Also,
yes.
Vomiting. It was severe in nature, intensity, and with projectile vomitals.
So, what is special about that headache is it is short duration headache. Now, at this age of 24, if the boy says that I am having headache from the age of 11 years or 12 years, it is coming on and off, unilateral, alternating, it's going to be a benign headache. But your patient is having a continuous headache lasting for 15 days. So it is a short duration headache lasting for 15 days. So that is very significant. So all short duration headaches are significant. So what is striking about the headache is a very common symptom. Everybody has headache. So this patient's headache, you should be alerted. As I have previously also told, headache at the bedside. Of course, the headache society classification is there, which is very, very complex. But at the bedside, you approach headache as a short duration headache and long duration headache. If the person has a long duration headache, if there is a recent change in the character of the long duration headache is the only question you will ask. If the long duration headache is going on in its usual fashion, then forget about that. But if there is a recent change in the character of the long duration headache, because people with tension headaches and migraine headaches are not protected from getting tumors or anything else. So if there is a recent change in the character of the headache, it is significant. Otherwise, short duration headaches are always significant. So short duration headache is very special in this patient. Second, short duration headaches are divided into short duration headache in sick patients and short duration headache in well-preserved patients. Very easy. So short duration headache in a well-preserved patient means it may be sinusitis, dental problem, systemic infections like viral fevers, no? Some END problem. So that is short duration headache in a well-preserved person, END, dental, minor systemic infections. So that is well-preserved patient. Short duration headache in a sick patient is neurologically relevant. So in your case, this person has got a short duration headache and is very sick. So that is the point you have to capture in his headache. My patient's headache is short duration and he is sick. So it is probably neurological. In the nervous system, you can have meningitis, you can have encephalitis, you can have cerebral hemorrhage, you can have abscess, no? You can have tumors. So all that is possible. So it's a short duration headache in a sick patient. It is neurologically relevant. Second, this short duration headache, where is it located? Is it having the features of raised intracranial pressure? Because now we think it is neurological. Short duration headache in a sick patient is neurological. So first question in the neurology, is it raised intracranial pressure? As I have previously discussed, the same symptom, raised intracranial headache pain is usually holocranial, but it can be occipital or it can be unilateral, rarely. It can be occipital because the posterior part of the nervous system has got a defective autoregulation. So raised intracranial pressure may be most felt in the occipital region. So patient may say occipital headache. Second, posterior fossa tumors. they can present with occipital headache. Otherwise, ICP headache is holochronic. And unilateral headache due to ICP happens in foramen of Monroe tumors. There will be unilateral ventricular dilatation because of the foramen of Monroe obstruction. Second, it can be CP angle tumors. They also expand in one side. So unilateral headache in ICP are exceptions which happen in foramen of Monroe tumors or cerebellopontine angle tumor. Occipital headache is seen either in posterior fossa tumors or it can be seen due to defective autoregulation. Even if the ICP is global, it may be experienced in the posterior region because of defective autoregulation. But generally, in the majority of cases, it is holocranial headache. Initial period, it may be relieved by analgesics, but later it will not be relieved by analgesic. It will awaken the patient from sleep. Why it will awaken the patient from sleep is because normally we start our sleep with NREM and we go on to REM. During REM sleep, you will have natural high pressure waves. Natural, they are called delta waves. You have got high pressure waves are naturally taking place in REM sleep. They are called delta waves. When the delta waves comes, ICP gets decompensated. As you know, there is something called compliance of the brain. The cranial cavity is a closed chamber in the adult. And you have got a brain, blood, and CSF. So anything that decompensates will go into the interhemispheric fissure, the sulcal spaces, and once they are compromised, it will produce ICP features. Normally, even if it is compromised, compensated within the compliance of the brain, when the high pressure waves come, it becomes decompensated. That is why whenever the REM sleep is coming, we fall asleep with NREM and we wake up with REM, and in between, in the middle of the sleep, you go into REM. So fall asleep, NREM, so you can comfortably fall asleep. When REM comes, patient will wake up in the middle of the sleep. And in the early morning, when REM sleep again comes, you'll get up with headache. So ICP headache is holocranial. Initially may respond to painkillers, later it does not. It wakes up the patient from sleep and it presents with early morning headache whenever the REM sleep is coming. So if those features are there, you have to elicit. Second, you can have amaurosis fugax. Because in ICP, there can be papilledema. And when there is papilledema, when you move your head, the edema fluid shifts in the layers of the ganglion cell layers of the retina, resulting in transient obscuration of vision, or due to stretch on the posterior cerebral artery across the tendorium, occipital lobe ischemia. So you will get episodic visual impairment, otherwise called amaurosis fugax. Next, you will get double vision. Double vision is because you know that usually it is a sixth nerve. Sixth nerve has got a very long intracranial course. And second important feature, it is not just long, it is anchored at the Dolores canal. So it is anchored at one point, and by ICP it will be pulled from anteriorly and pulled from posteriorly across the Dolores canal in the petrous apex where it is anchored. So it will get stretched at that point and results in a false localizing double vision. Next will be, you can have vomiting. So why do you get vomiting? Vomiting is a nature's method of sending out the fluid. It is like sending a mannitol. So by mannitol, we are removing the fluid through the urine. Similarly, nature tries to reduce the ICP by vomiting. How it happens? You have got two types of vomiting in neurogenic cause. One is the chemoreceptor trigger zone induced vomiting, which is against poisons. If you have taken a poison, again nature tries to protect you, where the chemoreceptor trigger zone, where the blood-brain barrier is defective. So the poison straight goes there, says this person has taken a poison. So you will vomit with nausea. That is chemoreceptor trigger zone. Whereas area postrema, again autoregulation is poor. Alteration in the pressures will be felt there. So projectile vomiting is induced. So you will get vomiting. So in your patient, it is a short duration headache. Your patient is sick and is having projectile vomiting. So that means there is intracranial pressure and brain is trying to bring down the intracranial pressure by reducing vomiting. Other features we did not get the nocturnal awakening, early morning headache, double vision, amaurosis, fugox. Those things were not there in the history, but he had a projectile vomiting. That means there is a nature trying to bring down the ICP. So that means there is raised intracranial pressure. So it's a short duration headache, sick patient. What is the cause of the headache? Because of the projectile vomiting, it looks like a raised intracranial pressure. And this raised intracranial pressure was associated with fever. Is it fever? Fever was there on chills.
Yes,
Low grade, not associated with chills. So you said there is a low grade fever, not associated with the chills. So what is the cause of raised intracranial pressure? May be infective. So now you have a patient who is having a short duration headache, and the short duration headache is associated with the raised intracranial pressure features, and he has a low grade fever. So the cause of the ICP may be infective. And what are the conditions where you have low grade fever and ICP, and high grade fever and ICP? If you have high grade fever and ICP, very short duration, it can be pyogenic infections or it can be abscess. Whereas if you have a low grade fever and subacute onset and ICP, it may be chronic infections. So from that low grade fever, you get the interpretation that my patient has got a headache which is neurological because it is short duration and sick patient, and your headache is due to raised intracranial pressure because there is projectile vomiting, and it is infective because he has fever, and the fever is low grade fever. Because it's a low grade fever, it is likely to be a chronic infection. So what are all the possible? So we are getting all these points. So what are all the causes for a chronic infection in a young person? That becomes the differential diagnosis from the symptom analysis of the first symptom. I think everybody understood. A short duration, sick patient. Short duration, well preserved means is systemic cause. Short duration, sick patient, neurological cause. And why is he sick? He is sick due to ICP because of projectile vomiting. So there is raised intracranial pressure. Intracranial pressure increased due with the fever. So it is infection. And the fever is low grade. So it is a chronic infection. So that is how you analyze the first symptom. So it's a chronic infection. So what are all the chronic infections which can cause raised intracranial pressure? One, it could be tuberculosis. Second, it could be brucellosis. Sometimes it could be rare infections like fungal infections associated with immune compromises. So you can, and sometimes you have got the amoebic infection which has got a meningoencephalitic presentation. It can sometimes have a subacute course, especially if they are people who are in the swimming like activity. So subacute infections, commonest is tuberculosis, and second is brucellosis, and third it can be fungal infections or immune compromised situations with rare infections, and very rarely you can have parasitic infections also, like cystic circus, very common in that part of the country, or you can have still rarer infections like N.I.M.H.A.N.S, which are very, very rare, but still it should be remembered. And so sometimes it can be protozoal like the meningoencephalitic form of amoebiasis. So these are the possibilities we will consider. So, how the ICP can come? The ICP can come due to hydrocephalus. ICP can come due to infarctions, infective vasculitis resulting in brain infarction, or ICP can come due to tuberculosis. ICP can come due to abscess, infective abscess of tuberculous nature or non-tuberculous nature. So now how are you going to know whether this ICP is due to granuloma, or is it due to abscess, or is it due to infarct, or is it due to hydrocephalus? That is the next question we have to ask. For that, you said that your patient is in altered sensorium. So when somebody is in altered sensorium, one, we will look at the depth of the consciousness. Second is the content of the consciousness. So depth of the consciousness is affected in your patient. Yeah, content you did not get any history. If the content is altered, it is delirium. So patient will be disoriented, he will be hallucinating, and he will be talking irrelevantly. That is content of the consciousness. That indicates hemispheres involvement. Whereas depth of the consciousness is involved, that means brainstem is involved. So ascending reticular activating system is there. So when that is involved, the depth of consciousness become affected. If the hemispheres are involved, the contents of the consciousness become affected. In your patient, it was the depth as per the history. Content, we did not get any history. He was not delirious. He was not throwing convulsions. He was not disoriented. But instead, he was drowsy. So there is a brainstem involvement. Is the brainstem involvement primary brainstem involvement or secondary brainstem involvement? That is the question. For that, when a person presents with altered sensorium, coma, semi-coma, stupor, so we categorize them into stupor with focal signs and stupor without focal signs. So if a person is stuporous and is a hemiplegia, then you know that it is due to a infective otitis or due to a tuberculoma or due to an abscess or a toxoplasma lesion. But if there is a altered sensorium without any focal sign, it is due to either uniform rise in the intracranial pressure or due to neurometabolic disorders, electrolyte imbalance, or any systemic cause like a chronic renal disease or chronic hepatic disease. So drugs. So it is stupor with focal signs or stupor without focal signs. From our history, our patient has stupor without focal signs. So it is unlikely to be due to an abscess or a tuberculoma or an infective vasculitis. He probably has got a global problem which is affecting the brainstem. Because of the headache and vomiting and which suggested ICP, the global problem could be hydrocephalus because it is stupor without focal signs. I'm sure all of you are following. So stupor without focal signs is either inside the brain or outside the brain. Inside the brain is uniform rise in the intracranial pressure which happens in hydrocephalus, or it could be a systemic cause like an electrolyte imbalance. It may be hyponatremia, hypoglycemia, uremia, or hepatic due to ammonia, or some drugs have been consumed. So these are the possibilities. In this context, it looks like a hydrocephalus. So now you understood how we have analyzed the symptom of headache, and we think that it could be due to hydrocephalus. I think I carried you through the steps. I think you understood. It is a drowsiness or altered sensorium without focal signs. Altered sensorium with focal signs has got a focal cause. Without focal signs has got a global cause. Global cause can be inside the neuraxis or outside the neuraxis. In this patient, he had headache, he had projectile vomiting, so it has to be inside the neuraxis, and that could be hydrocephalus. So that is the analysis of the first symptom. So he was treated, and according to you, did the patient improve?
Sensorium wise, ma'am.
Sensorium improved.
Yes, ma'am.
Okay. So he was discharged or he was kept in the hospital?
He kept in the hospital only.
Hospital. 15 days later. So now your patient seems to have a chronic infection which has led to hydrocephalus. It could be tuberculosis or it could be brucella, it could be fungal infections. All those possibilities remain there. So it could be a chronic meningitis with hydrocephalus. So now your patient is developing weakness of both lower limbs, and the upper limbs were spayed. And up to what level the trunk was also involved. He could not turn in the bed, you said, no?
Yes, ma'am.
Both lower limbs were completely paralyzed, or did they have any sensory impairment also, history-wise?
History-wise, no sensory impairment, ma'am.
No sensory impairment. So this person developed weakness of both lower limbs. So whether that weakness is in the upper motor neuron or in the lower motor neuron is the next question. So it's a motor paralysis of the lower limbs, upper limbs were spayed. So if there is a motor paralysis, we want to know whether it is a radiculopathy or is it a myelopathy. So that is the question. So that depends on the accompanying features. So was the limb flail or stiff? Did he have any flexor spasms? Did he have any sensory loss? All those things will be very useful. If those history is not available in the history, we can think of an element paralysis or human paralysis and discuss it for theory's sake. And then after examination, we will decide whether it is element or human. So in this patient, both lower limbs weakness, the legs were uniformly weak and the trunk was also involved, but upper limbs were spared. So the level of this motor weakness seems to be below the upper thoracic cord. So upper limbs were spared. So one thing which is very clear is whether it is LMN or UMN, it was below the upper thoracic region. So if it is below the upper thoracic, your trunk is involved. He is unable to turn in the bed, you said. So it is trunk is involved. So it could be a extensive radiculopathy involving all the several roots from the thoracic region. In that case, what will be the possibility? Second, and how are you going to differentiate? Second, it could be a myelopathy. Myelopathy below the upper thoracic cord. Yeah, the supporting features will be stiffness, pattern of senses. So between root and cord, how are you going to differentiate? One thing, radiculopathies generally tend to be patchy. Very difficult for all the roots to be involved below the cervical region symmetrically, uniformly. It is very, very theoretical, whereas myelopathy can be symmetrical. Second point between radiculopathy, radicular pattern of sensory loss. So you'll have a root pattern of sensory loss, root pattern of motor weakness. Motor radiculopathy happens in Guillain-Barré and its variants, or anterior Honsel-like disease, which happens with echoviruses. All those things you can have a pure motor weakness, but pure motor radiculopathy is relatively less common. At least the patient is not complaining. When you examine, you might find. Whereas myelopathy, you have a cord pattern of sensory loss. Third, you will have a root pattern of pain, whereas in the cord, you will have a tract pattern of pain. Fourth, bladder, if it is involved, you will have a element type of bladder in radiculopathy, and it will be human type of bladder in myelopathy. So those are the points which we will ask to know whether the weakness of the limbs is radiculopathy or myelopathy. So the limbs were symmetrically involved and they were severely involved, and there was a trunk problem. So symmetrical involvement is very, very less likely in a root. But root pains were not there. Did he have tract pains? The root pains are typically sharp, shock-like pains which are along the distribution of some roots. So it can be any root. So he did not have any root pain. So that is a little unusual for a extensive radiculopathy, nowhere producing a root pain. And third, first point I told, symmetry is unusual for radiculopathy. Absolute absence of root pains is less likely. And third, the limb will be flail. If it is a radiculopathy, the limb is expected to be flail. And sometimes if it is an acute, very rapid radiculopathy, after 15 days, patient developed a rapid radiculopathy, then you may get involuntary movements like myokymia. Myokymia is acute radicular denervation will produce myokymia. Chronic anterior Honsel will produce fasciculation fibrillation. Acute motor denervation will produce myokymia. Myokymia is a vermiform movement which involves a group of muscles and spreads across one particular muscle. So if you see quadriceps, it will be a vermiform movement, acute motor denervation. So that is called myokymia. So we did not find any myokymia, and when we examine the limb may be flail and the reflexes may be absent. And what is a classical LMN bladder? So it will be called, it is called as an autonomous bladder. So LMN bladder is an autonomous bladder, or it is a motor denervated bladder, or it can be a sensory denervated bladder. These are the various bladders you can have. If it is due to extensive radiculopathy or anterior hornsel involvement, motor radiculopathy or anterior hornsel involvement, you get a motor denervated bladder. This motor denervated bladder will be a painful bladder. But as you know that apart from the bladder wall muscles, the abdominal muscles are also involved in emptying. So when there is a radicular weakness, the abdominal muscles are unable to assist in the bladder function. So patient will develop retention. So this will be a painful retention. By God's grace, these conditions are very brief. Typically acute Guillain-Barré syndrome, very, very uncommon bladder, but they can have, then they get a painful retention, or acute anterior hornsel disease, polio and polio-like illness, brief period, then they start recovering, and that brief period you will catheterize the patient. That is a painful retention. Whereas sensory denervated bladder, if the sensory roots are involved, their patient is not appreciating the sensation. So patient will be a painless bladder. Patient will have a large painless bladder, but if he tries to empty the bladder, emptying may be possible. Only thing, because he is not getting the proper information regarding bladder fullness, he may not make an attempt to empty the bladder. So the big bladder will be there. He will be roaming around. Somebody will have to tell him your bladder is big. So go and empty by suprapubic pressure. He may be able to empty, but because it is a neurogenic bladder, there will be residual urine. That is the second type of element bladder. And third is the autonomous bladder. What is autonomous bladder? The autonomous bladder, the sacral center is damaged because of the sacral center is not getting any inputs. Sacral roots are gone. So the only thing that is functioning in the bladder is the bladder wall receptors. The beta receptors in the body and the alpha receptors in the sphincter are functioning. So the bladder will become very big. It will not perceive any sensation. It will not make any attempt to empty. When the bladder urine accumulated is 1.5 to 2 liters, the amount of urine secreted after that will continuously dribble. So autonomous bladder is a large bladder. The person does not appreciate any bladder fullness. Patient does not appreciate any pain. He cannot initiate micturition either voluntarily or by suprapubic pressure. But after the amount of urine is about 1.5 to 2 liters, it dribbles. So a large, painless, dribbling bladder is autonomous bladder. Large, painless, dribbling bladder. Whereas painless bladder, in which a person can voluntarily initiate partly and empty by suprapubic pressure, still have residual urine, is sensory denervated bladder. Motor denervated bladder is a painful retention with flabby muscles. So if the person says he has a large bladder and he is dribbling, that points to a element bladder. Myelopathy, it will go with a radiculopathy. Supposing it is myelopathy, it can be a partial bladder or an incomplete bladder. Complete myelopathy bladder is automatic bladder. Partial will be precipitancy and hesitancy. So patient may have difficulty in initiating micturition, then you call it as hesitancy. Patient will have to rush to the toilet once the sensation comes, that you call it as precipitancy. They are partial pyramidal bladders. When the facilitatory fiber is gone, you get hesitancy. When the inhibitory fiber is gone, you get precipitancy. But if there is a complete pan cord syndrome, then you get an automatic bladder. What is automatic bladder? The sacral center is preserved. So sacral center is there. The information from the sacral center is not going to the higher centers. As you know, the bladder can store up to about 200 to 300 ml of urine using the bladder wall receptors. At 300 ml, the information is sent to the sacral center. Sacral center can coordinate up to 300 to 400, 450 ml. And beyond that, the information is sent to the higher centers, where the higher centers, based on the social setting, based on the need, can contain bladder up to 1.5 liters. Here what is happening, the sacral center is receiving, so it can store up to 300 to 400 ml, and the sacral center want to send the information to higher centers to look for convenience. that information is not going up. So what happens? After the 400 ml of urine is stored, the sacral center automatically initiates emptying. So that is why it is called automatic bladder. So after about 300 to 400 ml of stored and the capacity of the sacral center is reached, it is unable to get higher command. So it starts emptying. So patient has no total loss or partial bladder fullness and pain appreciation depending on completeness of the cord lesion. If the cord lesion is a pan cord lesion, patient will have no sensory appreciation. If it's a partial cord syndrome, patient will have partial appreciation of fullness and pain. He cannot initiate maturation. Maturation becomes automatically initiated and a good amount of urine will be passed. About 300 ml will be passed and that patient cannot stop in the midstream. So once the automatic initiation of maturation takes place, he cannot stop it in the midstream. And completely also he cannot stop. It automatically stops. At the end, when the bladder wall capacity is reached, it stops. The bladder wall has got about 100 to 200 ml. So there will be a good amount of residual urine, which is not in the purview of the sacral center. And patient will have reflex. So because there is a residual urine and there can be a vesicoureteric reflex. And there is hyperreflexic bladder when you do urodynamic studies. So automatic bladder, the sensation may be partially or completely lost. He cannot initiate maturation. Initiation of maturation takes place automatically when the urine volume is 400 to 450 ml or beyond 300 ml, any amount. It is variable from individual to individual. And once initiated, patient cannot stop in the midstream. And it automatically stops with a good amount of residual urine. And this residual urine results in reflex. And when you do urodynamic studies, there is a hyperreflexic bladder or there is a high pressure filling. That is cord bladder. So if the cord symmetry, so in this patient, symmetrical weakness is favoring a cord involvement. And sensory, we are not getting a clue. So it is a partial cord syndrome. It doesn't look like a radiculopathy because it is so much symmetrical. So less likely to be a radiculopathy. And the type of bladder, you told me there is urgency. You told me some urgency and frequency. So what do you mean by urgency? What do you mean by frequency? Would you like to tell me? You want to tell?
When
What
the
is urgency? Tell me.
patient has a sensation to pass urine, that will be the urge. And frequency is if they go repeatedly.
So does she have a small storage bladder?
Yes, ma'am. Looks
So
like that.
urgency means it is an urge. So urgency is not necessarily a neurological symptom. Urgency happens in prostatitis, urethritis, cystitis. So it's urgency is a urological symptom. So it can happen when there is a complication in the form of infection or something. So whereas frequency indicates poor storage. So which part of the nervous system is involved in storage? Sympathetic. Parasympathetic is for emptying and sympathetic is for storage. So if there is a frequency, that can happen with several situations. So urgency part will ignore. Urgency part is not necessarily neurological. Whereas frequency indicates poor storage. So poor storage can also be due to, but you have to elicit the pre-voiding, voiding, post-voiding symptoms so that we will know what exactly is happening. Frequency is a poor storage bladder. And poor storage can be due to urological cause or could be due to neurological cause. Urological causes for poor storage will be intravesical tumors, large intravesical calculus, or due to chronic infections, radiation, there is a contraction and necrosis of the bladder. So contracted bladders due to radiation or chronic recurrent infections or due to tumors or due to large intravesical calculus, the storage becomes less in urology. Storage becomes less in neurology due to one sympathetic involvement. If this patient has normal bladder sensation and every other part is all right, but only he is having frequent micturition, then you have to think whether it is a sympathetic involvement. Because sympathetic is involved in storage, but it has no sensory or other functions. So frequency micturition without any other accompaniment may be sympathetic bladder, sympathetic involvement. Second common cause for poor storage is chronic catheterization. You put the patient on chronic catheter, the bladder fails to store anything for a long period of time. The bladder is not storing anything, so it will get contracted. That is called a transformed bladder. It may be an N.I.M.H.A.N.S bladder or it may be an U.M.N bladder. It is kept catheterized for a very long time, so it becomes transformed. It becomes contracted due to not at all storing for several months to several years. So it could be a sympathetic bladder if it is not accompanied by any other symptom. Then it can be a poor storage due to sympathetic. Second, poor storage due to transformed bladder of automatic bladder, autonomous bladder, U.M.N bladder, L.M.N bladder, any bladder. You keep the person under catheter for a long time, it becomes a transformed bladder and it does not store. And third cause for a poor storage is again automatic bladder. Yes, as I told, sacral center can store up to about 450 ml. So if there is some sensory motor involvement associated with poor storage, it can be an automatic bladder. Because beyond 450 ml, sacral center cannot store. So your patient is having frequency with poor storage. So it is not a pure frequency, what you get in a sympathetic involvement. He is having frequency with weakness. So it can be a partial cord syndrome with a partial automatic bladder. Sacral center may be partly preserved. Because of that, patient is having the capacity to store only up to 450 ml or so, but he is not having complete sensory loss. Complete automatic emptying is not there because it is a partial cord syndrome. So poor storage can be sympathetic, poor storage can be transformed bladder, poor storage can be automatic bladder, partial or complete, or sometimes you can have poor storage even due to psychogenic causes, or sometimes there is something called ritualistic bladder. Not in this case of psychogenic causes, they have frequent micturition. Then there is a Barrington syndrome in the basal ganglia. So patients with Parkinsonism, they have frequent micturition. So poor storage can even happen in basal ganglia disease. It can happen due to psychogenic causes or ritualistic emptying that happens in frontal lobe disease. A person with frontal lobe disease, multiple ritualistic features will be there. So person with dementia, he may be simply going to the toilet, coming out, going to the wash basin, spitting and coming back. So that is called ritualistic behavior. They feel compelled to do an act, whether even though the new bladder control is all right. This is seen in patients with dementia. So many times they will go to the toilet. They may pass urine, they may not pass urine, they'll come back. So that is ritualistic. So small storage can be sympathetic peripherally. Next, it could be a partial pyramidal automatic bladder. It could be a transformed L.M.N or U.M.N bladder. It could be due to Barrington center in the basal ganglia with accompanying Parkinsonian features. Or it could be a frontal bladder, which is ritualistic behavior. Ritualistic bladder, or it can be a psychogenic bladder. In this case, because there is a poor storage as evidenced by frequency and weakness, it is possible that it could be a partial automatic bladder. But when you describe a bladder, as you clearly said, number of voids per day and amount of urine also you should tell. This is supposing you are having a frequent micturition and the amount of urine passed is very high, then it is not neurological. It may be diabetes mellitus, or it may be diabetes insipidus, or there are people, some therapy, naturopathy and other things, they take a lot of water. That is called compulsive water drinking. So diabetes mellitus, diabetes insipidus, compulsive water drinking, they will have frequent micturition with good storage and they will pass large amount of urine. So bladder diary consists of number of voids per day, number of voids per night, and amount of urine passed at every void. If the amount of urine passed is less and the number of times is more, that becomes a neurological, and all these points I said you should. So the bladder diary will contain number of voids and the amount of urine pass. Second, you will ask about the pre-voiding phase. Is he able to appreciate fullness? Is he appreciating pain? Is he able to voluntarily initiate maturation? Can he restrain maturation till he reach the toilet? And once he initiate maturation, can he completely empty the bladder? Or if he has to stop, can he stop maturation in the midstream? And at the end of maturation, does he have double voiding? That feeling of incomplete emptying and something remaining back, and post-void dribbling. So pre-voiding phase, voiding phase, post-voiding phase, all symptoms you should ask. That will make the bladder symptom complete. You told frequency, you did not mention about the amount, you did not mention about the pre-voiding, post-voiding and voiding phase, other characters. If all that is available, we can make a probable diagnosis, whether it is a, but I feel considering the motor weakness with the symmetrical, with the a poor storage, it is likely to be a partial cord syndrome. So that's what I am thinking. Next symptom, what is the next symptom you said? He has no improvement from this, no? That is a symptom.
Yes, ma'am.
Okay. Then headache relapsed. Okay. So up to this, what is the possibility? Probably he has a hydrocephalus, which was explained by the first symptom. Second, he has a myelopathy, so two sides are involved. Myelopathy has spared the upper limbs. These myelopathies we generally categorize into one is compressive, non-compressive. Among compressive, whether it is extradural, intradural, intramedullary, and once you think it is a cord lesion is established, then you decide it into a pan cord syndrome, hemicord syndrome, anterior cord syndrome, posterior cord syndrome, and central cord syndrome. Pan cord syndrome means all the tracts, spinothalamic tracts, corticospinal tract, posterior column, everything will be involved. Whereas anterior cord syndrome means posterior columns will be spared. So if the posterior column is spared and anterior cord is involved, it indicates a vascular syndrome. Vascular syndrome. Because anterior spinal artery supplies the anterior cord. Posterior spinal artery supplies the posterior cord. It supplies only the posterior column. But you know there are two posterior spinal arteries. So posterior column involvement due to vascular cause is very, very uncommon. But posterior cord syndrome commonly seen in subacute combined degeneration, HIV myelopathies, copper deficiency myelopathies. So if it is a posterior cord syndrome, these possibilities you will consider. Anterior cord syndrome, you will consider vascular causes. Hemicord syndromes, usually tumors, ependymomas, gunshot injuries, or traumatic cord lesions, rarely demyelinations, and sometimes even vascular conditions. Arteria corona is there. Arteria corona links the anterior spinal artery with the posterior spinal artery. If that artery becomes affected, then you can have a hemicord. So hemicord common cause is trauma, tumors, and then you have got rarely demyelination and sometimes infarction. Then you have got central cord syndrome, that is trauma, whiplash injuries. Then you get a central cord syndrome. Second, you can get central cord syndrome in hydromyelia, syringomyelia. So that is central cord syndromes where we will have dissociated anesthesia, descending anesthesia, and L.M.N. signs at the top and U.M.N. signs below, early bladder if it is bilateral. That is central cord. But you are not having any of those features in this patient. He is having a motor weakness. So that is, and it is bilateral. So these are called tractopathies. So something which picks up the tracts, some specific tracts are picked up. That may be a clue. So, but we have to examine whether it is really a tractopathy. Because supposing you have got posterior column and you have got corticospinal, it is neither anterior cord nor posterior cord, but it is a tractopathy involving the posterior column and the corticospinal tract, which goes very well with subacute combined degeneration. Supposing you have got a tractopathy involving only the corticospinal tract, you have a group of conditions, hereditary spastic paraplegias, hereditary spastic ataxias, tropical spastic ataxias, they come under. So that is a tractopathy. Selective tract is involved. So this appears to be a corticospinal tract involvement from the history. And in this context of having a chronic infection, and there is evidence of hydrocephalus, and patient is developing a distant pathology, if it is purely tract, or if it is L.M.N., I will consider arachnoiditis. We thought it is less likely from the information that has been provided to us. L.M.N. appeared less likely, so it is less likely to be arachnoiditis. Second, can it be due to another level of vertebral pathology producing a compression, where it's a compressive myelopathy. Compressive myelopathies, compressions have a tendency to involve the most myelinated tracts. One is the posterior column, second is the corticospinal tract. So corticospinal tract will become symptomatic and posterior column may be asymptomatic. Even cervical myelopathy, all of you would have seen, patient will come with a spastic gait, and then when you examine, you find that vibration is impaired. So it can be a compressive myelopathy where the most sensitive tracts to compression or posterior column and corticospinal tract. Second, it could be due to tuberculoma inside the cord. So whether it is involving the some specific central regions and the corticospinal tract which are on either side, is it picking up? That is one possibility. Or as a hypersensitivity reaction to infection somewhere, is there is a demyelination of the corticospinal tract. So these are the possibilities if it is purely motor. So, but it is not purely motor, bladder is also involved. So that is how I will consider this is a meningomyelopathy. And meningitis with hydrocephalus is at one level, myelopathy is another level. So it is a disseminated disease in the neuraxis. Infections can be disseminated, specifically with reference to tuberculosis. Dissemination can be due to vertebral pathology, or it could be due to disc involvement, or it could be due to infarctions due to septic arthritis, or it could be due to arachnoiditis, or it could be due to tuberculous transverse myelitis or para-infectious demyelination. All this can happen. At this point, for the sake of revision, how do you know compressive myelopathy? There is a definite level. If it is at the vertebra, you'll have a gibbous, you'll have tenderness, you'll have paraspinal spasm, and especially vertebral pathologies are more symmetrical and bladder is late. So if there is a vertebral pathology producing compression, there can be gibbous, tenderness, paraspinal muscle spasm, and more symmetry, late bladder, and sensory motor. Compressions pick up the posterior column and the corticospinal tract. Spinothalamic tract is the last one to be involved in compressive vertebral. Intradural commonly they are tumors, meningiomas and neurofibroma. Tuberculoma is less common, but still it can happen. So intradural compression, the point is asymmetry, whereas extradural compression is symmetry with gibbous, tenderness and paraspinal spasm. Intradural is asymmetrical because eccentrically placed lesions, and they have no gibbous, they have no local tenderness, they do not have any paraspinal muscle spasm, and they are asymmetrical and bladder is late. That is intradural compression. Intramedullary compression, they involve the crossing spinothalamic and the ventral horns. So there will be dissociated anesthesia, suspended anesthesia, L.M.N. signs at the higher level, and the sensory impairment starts in the crossing and descends. So descending sensory loss, dissociated sensory loss, suspended sensory loss, L.M.N. at the top, early bladder if it is bilateral. If it is unilateral, it is late bladder. And myelopathy comes later. That is intramedullary compression. Non-compressive, how do you think? The upper level is very vague. there is no definite upper level. Upper level may be very ill-defined. Second, the patient can have distant signs. They can have an optic atrophy, they can have deafness, they can have peripheral neuropathy. So vague upper level, fairly symmetrical, distant signs, no gibbous, no tenderness, no paraspinal spasms, and so that is non-compressive. So vague upper level, presence of distant signs involving cranial nerves and peripheral nerves, and usually late bladder, unless it is an acute transverse cord lesion. So in this patient, you said that it does apparently it is symmetrical, but other features we have to examine. So whether it is a partial compression due to a vertebral pathology below, that is also possible, or did he have a demyelination in secondary to infection? So the diagnosis appears to be a meningomyelopathy. The meningitis is at one level, myelopathy is at another level. And are they due to, one due to infection and second due to compression or non-compression is the question. Symmetry is the point. Pure motor is a point favoring compression, but just only one tract is involved. Other tracts are not involved. We have to examine, and then we have to find out whether it is a tractopathy due to some other cause. So that we have to do exam. So this is a meningomyelopathy. So we have to think of the differential diagnosis for meningitis with myelopathy. One, again, as I said, tuberculosis. Second, you can have multiple metastasis, or rarely with brucella. Brucella can produce a parrot-beak appearance in the vertebra and vertebral compression due to severe osteophyte formation is well described in brucellosis. Fungal infections, very uncommon meningomyelitis. Viral infections can produce meningomyelitis. I will not consider primary demyelinating disease like multiple sclerosis at all. It will not be considered at all. This is not at all the picture, but para-infectious demyelination. So infective meningitis with hydrocephalus above and syn infectious demyelination below. That possibility cannot be ruled out because you told it is purely motor. So we'll keep it like that. The bladder. So from in this you have to know how to differentiate compression from non-compression, LMN from UMN. Then what all the pressure sensitive tracts. Posterior column and pyramidal tract is pressure sensitive. Ischemia sensitive is spinothalamic and autonomic, whereas toxins and nutritional, metabolic, degenerative, they produce tractopathies based on the specific picking up of the tract by one toxin or one deficiency. They are all tractopathies. So that you show, and how to describe a bladder. So this is after the history. This is a meningitis with myelopathy, and it is at two levels. So so the first diagnosis definitely tuberculosis. Even if there is no family exposure to tuberculosis, the first diagnosis is tuberculosis only, because that is very notorious for disseminated involvement. On second, does he have rare situations like brucellosis, fungal infections? And third cause, young person still can have multiple metastases. Then they can have a disseminated involvement, carcinomatous meningitis with the hydrocephalus, and another carcinomatous deposit elsewhere, like leukemias, lymphomas in young people, can have a meningitic presentation and a cord involvement. Rarely I will think of other rare infections like amoebic meningitis. They are not myelitis. Meningitis is not there. Fungal infections can produce, but they are also more infiltration, pachymeningitis, and which can slowly go to the spinal cord if the person is immune compromised. So the first diagnosis is tuberculosis. Second will be brucellosis. Third will be carcinomatous meningitis related to lymphoreticular neoplasm and myelopathy, or infection above and demyelination below. So these are the possibilities. Now you examine. So now you learn to describe the bladder properly. Urological bladder or neurological bladder. If it is neurological, frequency, amount of urine, pre-voiding phase, voiding phase, post-voiding phase. All phase symptoms you should elicit. Finally, sometimes it will be both neurological and urological also. This boy has been catheterized for a long time, so he would have developed repeated urinary infection. So urological characters could have been added to the neurogenic bladder. But all those things you should elicit and tell. Urgency and frequency is not sufficient. Little more expansion will help us to characterize the bladder. So this is at the end meningitis with hydrocephalus and another myelopathy, meningomyelopathy, most probably tuberculosis only. Next one. So on examination, you tell me.
Yes, ma'am. A young male, moderately built and well nourished, conscious, oriented to time, place, and pulse of 86 beats per minute, which was regular, normal volume, character, and the character and vessel wall was normal. All peripheral pulses were well fed, with no radial or radiofemoral delay. Blood pressure was 130 in the right arm supine position and 120/76 in the right arm sitting position. Respiration rate of cycles per minute. Temperature was 98.6 degree Fahrenheit. Saturation was 98% on room air. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. Head-to-toe examination, no external markers of tuberculosis, no neurocutaneous markers, no external markers of atherosclerosis, buffalo hump present.
What all the external markers of tuberculosis you look for now?
Lupus vulgaris, in case of the eye, we look for choroid tubercles or uveitis, and collar stud abscess, if there's any scar, scrophulodoma, pityriasis versicolor.
Lymph nodes, huh?
Lymph nodes, yes, ma'am.
Lymph nodes are very common. Skin tuberculosis is there, but unless the patient has come into AFB directly on the skin, it is very uncommon. But lymph nodes are very common. Okay. So cervical nodes, those things can be biopsied also. Epidermal males, epidermoarchitis, lymphadenopathy, and of course all other things you told are there, but less common. You should tell. Very good. Next one.
He has buffalo hump.
Why did you say about neurocutaneous markers?
Young age group increase. We thought of any CV junction anomalies. Didn't think of it.
Okay, but I don't think in this context it is relevant. Multiple neurofibromas can produce N-block meningioma, N-block neurofibromas. They can produce hydrocephalus, foramen magnum syndromes. It's all there. But in this context, it is less likely. Okay, no problem. External markers of atherosclerosis, you thought whether is it a vascular syndrome in the spinal cord? Very unlikely. Because as I said, anterior cord syndrome will be all the tracts in the spinal cord except the posterior column. Whereas second vascular syndrome happens in the spinal cord in the artery of Adam-Kevis, that is thoracolumbar cord. The arteria radicularis magna or arteria of Adam-Kevis is supplying. That will resemble an acute transverse myelitis because it supplies the whole cord. So classical vascular syndromes are either anterior cord syndrome or posterior cord syndrome. Second, Adam-Kevis resembles transverse myelitis. Third, you have got watershed lesions due to vascular involvement. That happens in compressive myelopathy. That is a different thing. If you have a higher cord compression, watershed area is C4, D4, L1. So if it is CV junction, you may get a false vascular level at C4. And if you have a lower cervical lesion, you may get a false vascular level at D4. If you have a lower thoracic lesion, you may get a false vascular level at L1. That is because of the ascending and descending radicular arteries meeting at certain places, resulting in watershed areas in the spinal cord. So classical vascular lesions in the spinal cord, one, anterior cord syndrome, posterior cord syndrome. Second, pan cord syndrome due to artery of Adam-Kevis. Hemicord syndrome, as I mentioned, very rarely arteria radicularis, that is arteria corona, which links the anterior spinal artery and the posterior spinal artery. Fourth is false localizing vascular syndromes due to compression above. That watershed areas are C4, D4, and L1. Then I am sure all of you know that cervical spondylotic myelopathy patients have a venous watershed. So most of them will never complain also. When you examine, you find small muscles are wasted. That is a venous watershed taking place in CID1 region. So these are the vascular syndromes. So I don't think I will consider a vascular when it is a pure motor from the history. After examination, if you found something else, it is okay. So he is having buffalo hump and moon face. Maybe he is on steroids. Okay, then ma'am.
He had a scar, ma'am, because of the surgery he had done in the occipital region, and no BCG scar. Though he gave history of the
All this
occipital.
via are due to steroids maybe, no?
Yes, ma'am.
What is that inverted U-shaped scar?
Ma'am, whenever he underwent VP shunting, there was a scar in the occipital region, and also an abdominal scar was present, ma'am.
Inverted U-shaped.
Like
Okay.
the scar.
Inverted U means like this. Okay. Usually it's usually a circumferential scar in the parietal region, but the occipital region is very unusual. Maybe the occipital horn was dilated and they put it or not, I don't know. It is not U-shaped, it is usually circumferential. Okay, we'll keep it in mind. Then what happened?
Uh, Nervous system examination, ma'am. He was right-handed, high mental function, he was conscious, alert, cooperative, oriented to time, place, and person. Language was normal, speech normal, no hallucinations or delusions. MMSE was 30/30. There
Okay.
was no significant cranial nerve involvement, ma'am, in any of the
Fundus is normal, huh?
fundus is normal, ma'am.
Okay.
So coming to the motor system examination, attitude, the patient is in supine position. The upper limb arms are placed by the side of the body. The lower limb, bilateral hip joint and extension, bilateral knee joint and extension, and bilateral ankle joint and plantar flexion with extensive spasms present by the patient. Bilaterally, there was no significant difference or suggestive of wasting. Upper limb, there was hypotonia, there was spasticity bilaterally, and even in the lower limbs, there was spasticity bilaterally. Power, in case of the upper limbs, on the abduction, we felt it was weak, more in the left and right. So on individual muscle examination, the deltoid was found to be weak, ma'am. Overhead, like after 15 degrees when we tried to abduct, all other movements on the upper limb was found to be 5/5. Whereas at the lower limb, movement of the hip joint was 2/5 bilaterally. At the knee joint, it was 2/5 bilaterally. At the ankle joint, 1/5, and toe movements 1/5. Trunk muscles, the flexors were weak, extensors were normal. Superficial reflexes, corneal reflex, corneal conjunctival present, abdominal upper was present, middle and lower was absent, cremastic reflex was absent, plantars were extensor plantars. Systemic reflexes, biceps.
Biceps was exaggerated, huh? Upper limb reflexes also.
Yes, ma'am. All of
More
them were
than normal.
exaggerated.
Okay.
Yes, ma'am. And clonus was there. It was a sustained clonus. And plus, sensory system, ceramic sensation, pain, temperature, pressure was intact bilaterally. Posterior column sensation, fine touch, vibration, and proprioception were found to be intact bilaterally. And postural sensation was also found to be intact bilaterally.
Did you look for a subtle posterior column, like timed vibration, dynamic joint sense?
That I didn't do.
Because pure motor, we have to be very careful whether anything more is there. Okay. Next.
Cerebellar system, finger node stress was normal. Heel shin could not be elicited. No dystidocokinesia. Rebound phenomenon was absent. Gait could not be assessed, and no meningeal signs. No spinal tenderness, gibbous, or spinal deformity seen. Was within normal limits, except for the surgical scar present in the right hypochondriac region.
Okay. So, did you have any spasticity before this infection came?
No, ma'am.
Asymmetrical? Was it asymmetrical?
Ma'am, like upper limb, like there was more weakness on the right side than the left, ma'am.
How much was the difference?
Ma'am, I felt 4 minus and 4 plus by 5. Very
You
minimal.
written parasagittal. So you thought it is cerebral paraplegia?
No, ma'am, I thought it could be both, actually, cranial and spinal cord involvement.
No, the unique feature is first tell me for theory's sake how to differentiate cerebral paraplegia from spinal paraplegia. Both of the cerebral paraplegia generally does not involve the upper limbs. It involves the lower limb. Whereas spinal paraplegia, depending on the level, upper limb and lower limb can be involved. Second point, cerebral paraplegia will have cortical sensory loss, because behind the motor cortex of the lower limb, there is a sensory cortex. So when you examine, you will get cortical sensory loss. Whereas in the spinal paraplegia, you will get posterior column and spinothalamic tract and not cortical sensory loss. Third point, in cerebral paraplegia, you can get focal seizures. Patient can have jerky movements which spread like a Jacksonian march. Whereas in spinal paraplegia, you get clonus. So in your patient, there is clonus. So clonus never happens in cerebral paraplegia. Whereas focal seizure is the equivalent of clonus in cerebral paraplegia. The next point is paraplegia in flexion never happens in cerebral paraplegia. Whereas paraplegia can be in flexion or extension depending on the completeness of pathology in spinal cord. Next is the type of bladder. Cerebral paraplegia, bladder will be frontal uninhibited bladder. Whereas in spinal paraplegia, it is automatic or autonomous depending on the sacral cord is involved or not involved. So in your patient, he has got a paraplegia. He has no cortical sensory loss. He has no seizures. Instead, he is having clonus. And he is having a partial automatic bladder. So this is not a cerebral paraplegia. Okay. That part is very clear. Only unique feature of your paraplegia is it is purely motor. So purely motor is whether you carefully look for sensory, I do not know. The purely motor is very, very unusual, and purely motor is seen in a tropical spastic paraplegia, hereditary spastic paraplegia, or it can be primary lateral sclerosis, variant of M&D, no? Or you can get a pure motor during the phase of evolution of a compression. And very rarely due to demyelination, even then it should not be bilateral symmetrical. It is fairly symmetrical. I don't think that much asymmetry is there. So pure motor is usually seen with non-compressive myelopathies. Arachnoiditis is very, very unusual because arachnoiditis typically is a painful condition. It's a radiculopathy. It's a painful radiculopathy, extremely painful in the limbs. You said he had only headache. He did not have pain. So arachnoiditis is very, very painful and it will have radicular involvement. Instead, you can say that tuberculous arachnoidal cyst. Sometimes arachnoidal cyst can be there and the cyst can compress. But when they compress, as I said, compression picks up the corticospinal tract as well as the posterior column. They are the pressure sensitive tracts and the posterior column may be asymptomatic. So in this case, you should look for timed vibration, dynamic joint sense, and look for reduced. And then there is another thing called VMP, vibration, movements, position. So vibration may be normal, movement may be impaired, position may be normal because there is a lamination in the posterior column. Vibration is the ventral, movement is the middle. So one you look and leave it off, other may be affected.
Okay, ma'am.
So definitely you should look for VMP, we call. Vibration is ventral most, movement is middle, position is dorsal. So differential involvement can happen. We just look at the joint sense and forget to look at the position sense. That may be the one which is pointing out here posterior column involvement. So timed vibration, dynamic joint sense, and this involvement of any one of these, vibration, movement, and position, you should look for. If all that is absent, purely motor weakness, in this case, has to be considered as compressive because it's bilateral. Demyelination will be patchy. Hypersensitivity reaction to tuberculosis is very common. You know that it's systemically also it happens. It can happen in the neuroaxis. Systemically, joints can be involved. You call it as Ponset's disease. Similarly, in the neuroaxis also, hypersensitive demyelination happens in the optic nerve, or it can happen in the spinal cord. But bilaterally, it is very unusual. One may be involved, other may be not involved. Like that, if it is there, we can see. Otherwise, it is a theoretical possibility. So I feel that there may be some degree of involvement of posterior column, which we have to look for. By subtle posterior column, as I said, VMP dissociation. Then timed vibration, dynamic joint sense. and 1 degree movement. If that is involved, I will think that either the person has got a arachnoid cyst that can present like a compressive myelopathy, or does he have a tuberculoma somewhere in the lower cervical cord, which because by reflexes the cervical is also involved, or does he have any pachymeningitis? Tuberculous pachymeningitis can also happen, but then it will never be purely motor. Purely motor has to be confirmed by looking for subtle sensory. So I think it is a compression in the cord, either by a pachymeningitis or by a arachnoid cyst, or it can be a disc itself, because disc is the first structure to get involved in tuberculosis. So there is a tubercular discitis, I don't know, and there is a definite meningitis. So you have the investigations, huh? You have the images?
Oh, yes, ma'am.
Sure. You should definitely tell that the odd feature in this patient is pure motor. So all effort will be made to find out subtle posterior column. If that is not there, he had seizures before. Did he have any spastic paraparesis before? We don't know. HSP plus, you have got HSP plus syndromes where you can have memory, Mendel's abnormality, you can have seizures, you can have thin corpus callosum, you can have cerebellar involvement. A pure HSPs, you don't have anything else. HSP plus can have seizures and all those things. So did he have it? We don't know, because he said some seizures. And pure motor, if you confirm it, whether it is a DL pathology. Currently there is a meningitis, and the meningitis decompensate the pre-existing myelopathy. So that we will have to seriously discuss, as a dual pathology also becomes a possibility. Show me the images. Okay. So now let me see. If we see the spinal cord, I can see the C2 very well. Atlantodental distance is normal. C2, C3 dispace is normal. C3, C4, C4, C5, C5, C6. There is a mild posterior dislocation of the disc is there. And the cervical lordosis is obliterated. And there is mild kyphosis in the thoracic cord. All the dispaces in the thoracic cord are well preserved. The anterior spinal line, the posterior spinal line, and the spinolaminar line are fairly parallel. There is no subluxation. I am not finding any prevertebral soft tissue shadows. I am not finding any thick ligamentum dendriculatum. And I do not find any demyelinating plaques. In the views that you have provided to me, I am not finding any signal changes in the cord. I'm not finding anything. Axial cuts do you have?
Ma'am, this was the first one. The more recent what we have is this. This is more recent one.
Okay. So this is the brain. No, this is the recent spinal cord.
Yes,
okay. Yeah, this is the T2 weighted image, which is showing a long central hyperdense shadow extending from the cervical cord down. So has he developed a secondary syrinx or hydromelia? It looks like that. In the central cord, there is a hyper intense signal change extending from lower cervical downwards. So probably he had a meningitis with myelitis. Maybe it was an acute tuberculous transverse myelitis at that time, and it went on to necrosis of the cord, resulting in a syringomelia or hydromelia line. From here to here, I am finding a signal change. From here to here, this looks like a dilated central canal. So maybe he had a acute myelitis. Tuberculous transverse myelitis is there. This is radiological, because clinically you have a pure motor, so very difficult to call, but radiologically there appears to be a post-infective syrinx, dilated central canal is there. Otherwise, I do not find anything. So This could be the culprit, but clinically with this picture difficult to diagnose a central canal dilatation. And in the brain, we find that there are hyperintense signals in the FLAIR images involving both the temporal region and on the left capsuloganglionic region. I'm not able to see it very clearly because they are very small images. If you can magnify, it will help me to interpret the brain. Can magnify, yes. So you find some hyperintense signals in the region of the caudate on the left side, and then the insular region. And there is really no hydrocephalus now. Maybe he had it before. So I am not seeing any ring lesion. So this could be gliosis, sequelae of old lesions. So meningeal enhancement I am not seeing. Did he have hydrocephalus in any of the old images? Because he said underwent shunt. He must have had.
We didn't have those images right now. Like
Okay, now there is only gliotic changes are seen. That is, I feel it is gliosis, and there is slight pushing of the third ventricle to the right side, and the left lateral ventricle is little larger than the right, and there are gliotic areas. So there is now it's an end-stage disease with cerebral and spinal gliosis resulting in a dilated central canal, which is probably the reason for the myelopathy, but it is clinically difficult to diagnose when there is only posterior only spastic weakness. Dilated cord should present like an intrinsic cord, then it is easy to diagnose. So this becomes a clinically difficult situation, but myelopathy can be explained by what you have shown. It can be explained, but we have to imagine, because hydromyelia or syringomyelia, we expect something else. But when there is, unlike a syringomyelia, which is eccentric dilatation and ventrolateral, then you get the classical pictures. When it is a symmetrical dilatation of the cord, the classical picture may not be there. So now retrospectively correlating with the imaging, this is a myelitis. Patient might have had a acute myelitis, and that has become necrosed and has converted into a hydromyelia, and this is very typical. You are having so many lesions in the suprasellar cistern, which is the preferred area, and you have got the, so these lesions which are in the avascular area in the cisterna ambiens, suprasellar cistern, the drug also will not go and act because these lesions do not have that much vascularity. The drug level will be very, very less. That is why they have an indolent course, even if the patient takes proper treatment. And it's a very typical location for the suprasellar cistern and the ambient cistern. So many of them are there. Such situations, in the olden days, people used to do a burr hole that will break the blood-brain barrier and the drug level will go better, or you can do intrathecal medication, because these are avascular areas, the cisterns. So the drug penetrance will be poor. So that is why they get into more complications and a prolonged course of the disease. Okay. This is typically tuberculosis only. And so it is now tuberculosis, meningitis with hydrocephalus and myelitis leading on to necrosis of the cord and hydromyelia causing myelopathy with bladder. Okay. So in this case, we took the help of radiology because it is an atypical presentation of the cord, PR motor. But I think you should check for subtle posterior column. So how are you going to treat this patient? Disseminated disease, neuraxis, you should not use the dots. I'm sure you know that. And you have to give a prolonged course. Always I say treatable disease, over-treat. So do not give any short course. So no dots, no short course. You should give the full 18 months course, 4 drugs to start with, 2 drugs to follow. And you should notify that you are having lesions in the avascular area in the cisterns. That should be conveyed to the patient, and this person is lucky. Otherwise, many of them become blind. So intrathecal should be offered in such situations to improve the blood level in the cerebrospinal fluid. Intrathecally, we generally give streptomycin. Streptomycin, you know that you can give about 10 milligram can be given intrathecally along with hyaluronidase. Along with hyaluronidase, it can be given. And you should check for drug resistance. And if you find any resistance pattern, it should be addressed appropriately. And steroids should be given to, it is given at the rate of 1 to 2 milligram per kilogram body weight, along with ATT for the first 2 months and then tapered. And unless there is a tuberculosis of the adrenal disease, adrenals, there is no indication for permanent steroid therapy. It is 1 to 2 milligram per kilogram for the first 2 months and later taper it off. And here we should consider intrathecal hyaluronidase with streptomycin. Sorry, not 10 milligram, it is 100 milligram. Intrathecal 50 to 100 milligram of streptomycin along with hyaluronidase will be very useful in reaching the unreachable spaces if it is sensitive. Any doubts, ma'am? So PR motor myelopathy, you should go back and check, and next class you tell me whether any posterior column involvement was there.
Okay, ma'am.
Okay, good. Thank you. You presented well only. Yes, spinal cord involvement, the features were not typically fitting in. So we had to consider, take the help of imaging. Some situations we take the help of imaging to localize, otherwise clinically only we do. So here it is not the typical central cord syndrome. So we had to depend on the radiology. Okay, any doubt, ma'am? Today go and read the spinal cord ascending tracts, descending tracts, vascular supply, compression, non-compression, types of bladder. Try to describe and use it in every case. Any doubt is there?
No,
Any
chats
question?
there is no doubts. In YouTube there is no doubts.
Okay. But I will want you to tell me timed vibration, dynamic joint sense, dissociation between vibration, movement and position to be specifically checked in this case. I expect that something may be there.
Okay.
Okay, because even the central cord dilatation is not presenting as an intramedullary compression. It is presenting as a cord compression. Intramedullary compression, as she said, it will be dissociated, suspended, descending. Sensory features will be more. That is not there. So it is due to central cord dilatation. So it is presenting due to pressure symptoms inside the central canal. So that should involve the posterior column. So that I think it will be there. You just examine and tell me. Thank you. Thank you for calling me and thank you for presenting. Thank you so much. Okay.
Thank you, ma'am.
Thank you. Thank you.